who ended up getting tubed in the CTICU. And I think there are at least 4 people at fault for that.
At least. Jenna, I don't think.
2 people and 2 entities, right? Deal with the guidelines and bloody stinking epic. And we'll get through kind of all of this over the next little bit. But as I went home last night, the more I thought about it, the more I'm kind of like, you know, we're a little stupid at times with this dogmatic, everybody must be on the same meds. And I think it hurt this guy. So here's a 77-year-old guy, history of ischemic cardiomyopathy, central sleep apnea, and chronic pain from spinal stenosis, who presented with weakness and dyspnea. He had a CardioMEMS placed in December, and his PAD had been ranging from 27 to 36, and we've been slowly kind of jacking up his Lasix dose. On the 10th, he called feeling weak. He had a PAD of 33, his creatinine was 1.2, so we gave him extra diuretic. He presents to the emergency room on the 13th, still weak, now intermittently confused, and having 3 episodes of collapse. Not truly syncope, but just kind of, I stood up and I felt so bad that I dropped. Denied any chest pain, nausea, vomiting, palpitations, abdominal distension, edema, orthopnea, PND. But in the ED, has a troponin of 2.5 and a BNP of 1340. And so, if you go to Epic, this is his lovely past medical and past surgical history, which is really pretty useless when you think about it, right? So, he has arrhythmias, AFib, and then he also has AFib, basal cell, a murmur, hypertension. His back is missing several vertebrae, 2 PEs, and a stroke. He's had nappy, he's had a ton of procedures. You have no earthly idea what happened really on any of those. And he's had 3 cardioversions and then a implantation of a wire pressure sensor. So not really a lot of good help there in terms of what's going on historically. Here's his exam. So 110, 73, heart rate 110. He's alert. He's irregular. He's got no S3, can't see his JVD, no edema, some crackles, his GI soft, and you see the rest of it, nothing really significant. So stable, blood pressure 110, heart rate 110 from that standpoint. Here are his labs, creatinine 1.2, sodium 130, K42, again, BNP 1340, which is up from kind of chronically about 700, and his troponin 2.5. What do you want? EKG. Anything exciting, Mr. Always? AFib. You know, maybe he's got some goofiness here, but I will tell you that 2 months prior, completely the same. So nothing in terms of SD, T-wave changes that get you really excited. He had an echo in November, EF25, biatrial enlargement, severe aortic stenosis, and this is just from the reader by echo, but is not correlated by cath. And so in January of 19, he had a cath and he had a gradient of 20 across his aortic valve, at which time his aortic valve measured out to be severe aortic stenosis with a valve area of 0.5. And so the thought is that for whatever reason, echo and cath don't correlate in him. And so here it made the impression aortic stenosis by echo is not correlated with cath, still measured as severe. And then his last cath, again from January of 19, he's got a stent in his LAD that was open. His circ's 100% included chronically, and he's got a 40 to 50 in his RCA that really looks about the same. Anything else you want to know? recent right heart cath from December, had a wedge of 23, a PA of 10, excuse me, RA of 10, his PAs were in the low 50s. There. Anything else? So here were the 6 problems addressed on the assessment plan. For his NSTEMI, is this an NSTEMI? Because, sorry.
He's overloaded.
Right, so it's more apt to be heart failure than it is an NSTEMI. What kind of proponent do you worry about with heart failure from a leak standpoint? Or when do you not attribute it to heart failure? Maybe it's a better way to do it. 5, 10? Yeah, I think above 5 is reasonable, and below that, you can really think that this is potentially a heart failure.
And it is trending up too, if it trends up instead of stays
Yeah,
flat.
instead of flat. And so his was 2, 3, 6, and then 2, 5, 8, was kind of his course. And no chest pain, no EKG changes, nothing else from that standpoint. From a heart failure standpoint, I can't assess his neck veins, his BNP is higher. You know that the day before, he had a PA diastolic myocardium of 33. Got some diuretics for that. What do you want to do?
I feel really worried about his aortic stenosis. The question I guess I have is, does the cath rating rule out the possibility of like low flow state worsening? Because you're saying it was moderate at one point and it was severe because it was 0.5, so.
Severe by echo, at the time of the echo, a gradient of 20 by cath. With an output at that time, that was normal.
Was it?
Yeah. So probably not, and you missed it because I didn't say it.
Okay.
But yeah, you've got this aortic stenosis in the background, so do you want to aggressively diurese him?
No.
And he's not that short of breath, he's got some crackles in
Check his
his lungs.
cardiomyomes again, it's day before.
Yeah.
His cardiomyomes, see what his volume
Yeah.
is, but you don't wanna drop his two of
Yeah, so what do you want to do with his ACE and beta?
What's he on?
What's he on?
What medications is he on?
Nothing, just Lasix 80/80. Blood pressure 110. With aortic stenosis, would he benefit from afterload reduction?
Yeah.
Probably a little bit, yep. What about beta blockade? His heart rate's 110. If he had a longer filling time,
You're saying it doesn't look that decompensated, and we get a repeat echo that his function is still normal, or how do you
Repeat.
It's 25.
EF's 25 chronically, yeah, and that happened the next day and unchanged.
it. But with his, like, pre-syncopal things, I'd be concerned about the AS getting worse.
So maybe not drop his pressure.
It could be a driver that you're pulling as well. Just about. If you're having new symptoms or anything like that.
If he's stable at a heart rate of 110, do you worry about his AFib? He's on anticoagulation. Yeah, it does not need to be cardioverted or anything like that. Hypertension is there, not an issue right now. History of PE, continuing anticoagulation, sleep apnea, continued BiPAP. We should talk sometime about BiPAP and central sleep apnea. It goes that way, right? We should talk. So, this is, acute combined heart failure, last known EF 25%. Cardiomyocytes in place, recent readings have been high. We'll order IV Lasix 80 BID, and was on 80 PO at home. We'll check daily readings. Wife brought pillow in, not on ACRB at home. Question presumed due to CKD. His creatinine is 1.2, so maybe not. Continue home Spiro, adding low dose beta for MI. Again, do we think he had MI? Monitor daily weight, size, nose, low sodium diet, heart failure to see on Monday, and then ischemic cardiomyopathy at 25, not an ACE for beta on clear Y, adding low dose beta. We'll hold off on ACE due to soft BPs and CKD. Is kind of the plan. Forget this. So next day, there's a note at 3, worsening hypoxia, hypertension, mental status, all getting worse, ended up being intubated, and here's his right heart cath on levo because he dropped his pressure to 80. So RA10, PA49, wedge 23, so not a lot of fluid, index 1, 2. And so my thought is that this is probably the beta blocker that tipped him. And if you go back, you asked me about his right heart cath, but I didn't say that his cardiac index in December was 1.4. And so it gets to this kind of question of when do you not give a beta blocker to somebody despite S. Russell, Jana, get with the guidelines, everybody else saying give a beta blocker to everybody with heart failure. Because potentially this contributed to the whole thing. Maybe not definitely, but I think it and certainly got it, and just the nursing notes describe this kind of I have no cardiac output kind of sensation, right? And this is on levo, yeah, index 1, 2, so who knows what it was pre-levo. And so, yeah, here's the right heart cath from December, index 1.4 at that point, which is why he wasn't on a beta blocker, because Russell's a chicken and didn't put on a beta blocker with an index 1.4, acting like he had low cardiac output type symptoms. And in fact, here's my note. Ready for discharge, won't tolerate either ACE or beta. And in the hospital in November, he was usually running a blood pressure in the 90s. And this is why Epic's at fault, because nobody's gonna go back to the 50 millionth Epic note to see what everybody thinks about it. And so at least Tanya and I have talked about, we're gonna try to do a better job putting in our notes in bold, or we tried this and hurt somebody or something like that to clarify why we are on doing what we do. But I thought I would just spend a couple minutes on beta blockers. So this is from Grunwald, which is the Bible of cardiology. In '92, beta blocking agents must be used with extreme caution in patients with heart failure. Undesirable effects include depression of contractility with hemodynamic deterioration. And this is pre all the data that showed a mortality benefit in patients with heart failure, but post data giving IV beta blockers to people with heart failure showing badness happening, which is why this kind of came up. I don't know, I keep clicking twice. And so here's one example, just looking at EF by MUGA in patients that were randomized either metoprolol or placebo essentially, and you see that acutely you get a drop in ejection fraction, right? It's only 3 or 4 points. But you get a decrease acutely in ejection fraction on beta blockers that then over time, by month 1 and month 3, actually heads in the right direction. But that's kind of why all this, if they're wet, don't start a beta blocker, because you do hurt them initially before they kind of head up in the right direction. Here's another study looking at incidence of adverse events in class 4, so you can see worsening heart failure, 22% versus 10%, with everything else really staying about the same. But we can occasionally hurt people that truly have class 4 heart failure, I think, with beta blockers from that standpoint. All that said, Jana would get mad at me if I didn't talk about the benefits of beta blockers.
Very victimized today. I said a word.
So just remember, long term they're good. Short term, you always kind of have to have that thought in the back of your head. Are they dry or not? Are they really low output class 4 because maybe they need some beta agonism and you don't want to block that sympathetic tone that is cranked up in them. And here's data supporting it, a ton of trials now, all supporting a reduction in mortality in patients on beta blockers. So this is a combination slide of all the clinical trials with beta blockers. And so the sickest group of heart failure patients studied was in Copernicus. Copernicus is really kind of sold as patients with advanced heart failure, randomized to placebo versus carvedilol. And so if you look at the placebo arm of that, that's a group that were on ACE, DIG, and a diuretic, and you compare it to Consensus, which is the first kind of ACE inhibitor trial, you can see that patients in Consensus who truly were class 4, mortality rate of about 50% at 9 months. The Copernicus ACE, DIG, diuretic group is not as sick, right? So truly class 4 end-stage patients were not studied in Copernicus. If you look at the placebo arm of Copernicus, no benefit from a beta blocker. PRAISE was a class 3 trial of amlodipine versus placebo with a background of ACE, DIG, and the diuretic. And even there, all class 3 patients not as sick as the Copernicus arm. So we don't have beta blocker drug reps anymore, but they used to walk around and saying, oh, you can give carvedilol in advanced heart failure based on this trial. That trial did not really study sick as a dog patients in the hospital. And so just to always remember, if you've got a Consensus type patient that you think is going to be dead in 6 months, never has there been a study showing the benefit of a beta blocker in them. You guys know this. Stable outpatients is really where it is, right? Now what about in MIs? Clearly, giving patients beta blockers associated with reduction in mortality, sudden death, non-fatal infarction. What about MIs in heart failure? Been studied in Capricorn. Capricorn had Capricorn, how do you like that? Confirmed MI within 3 to 21 days, right? After you have your MI, within 3 to 21 days, you get randomized into this. Not at the time that you walk in the door, post-MI, when you're stable, EF less than 40, on an ACE inhibitor for at least 48 hours first. Most of the patients were involved were hospitalized. Again, post-MI up to 21 days, you don't have to get it on right off the bat. If they're having angina, then that's the reason to start a beta blocker right off the bat. But if they're stable, you can get it on before they leave, but you don't have to start it on day 1, which was kind of the mandate here. If they're stable, right? If they're not having angina, you want to get it on when they're stable. What are you going to say?
Within 24 hours of onset of symptoms, unless they're in cardiogenic shock, I would argue, right? Like,
Based on what data?
doesn't the commit trial start at that early? And when you go back and look at like the BHAT study and everything,
If you've got
From like
normal
that.
MI, I'm talking about heart failure here. I mean,
Okay.
normal EF, yes, get it
Okay.
going. But if you got baseline heart failure, this is probably the best data that's out there. Because all those early MI trials did not include heart failure patients.
are you saying heart failure just like I have a reduced EF after the MI, or like I'm symptomatic with heart failure?
This was just EF low. Whether they walked in with it or they developed it post-MI. That's it. That's all there is. And not that you don't want to get somebody on a beta blocker as quick as you can, but have a grain of salt, especially in a case like this when potentially it was not an acute MI. It was just, type 2, low flow, strain type MI. That said, it works in that setting, but just have a grain of caution, what I'm shooting for here. Beta blockers into acute decompensated heart failure. There was a B-Convince trial published in EHJ and randomized patients who came in on a beta blocker to either keeping it going or stopping it and restarting before they left the hospital. So do you need, trying to answer this, you need to keep patients on their beta blocker when they're in the house.
I didn't quite catch that.
So small trial, right, 100 and whatever, 30 patients. European, so longer length of stay, 9 days. no difference in mortality, and at 3 months, no difference in mortality, et cetera, et cetera. With one exception, right? Less patients were on a beta blocker if they had it stopped. So despite the, you must start it before you go home, less of the time did that happen. And so you wanna get them back on, but if you're worried about acutely, beta blockers, you can stop it and be okay, and you've got data to support stopping it. This is from the optimized registry, and the big group is those who had it withdrawn. The trouble with this trial, they tried to standardize patients, so you have 20 in each group with a creatinine of 1.4, but how do you really know, right? So somebody comes in sick and their beta blocker stopped and not restarted, they're probably sicker than the group who had it continued throughout their stay. But in general, stopping it in red, higher mortality than either starting it, keeping it going, and interestingly enough, in green, never getting it either before or after. So okay to start it, okay to stop it, restart it before they leave. And that's all I got. So think about beta blockers. Know that Jana's gonna text you the next day, and that Russ is gonna send you an email saying this patient was discharged, not on a beta blocker. But truly for the class 4 sick patients, really be cautious about it and think about it. Go back and look at Right Heart Cath. I don't have a good number for an index of who should or shouldn't be started on it. Because we have some people chronically with an index of 1.5 who are on it and are doing okay with it. But at least acutely, low is bad. And I think this is an example of probably when it proved out to be. And again, the guy's sick. He's not gonna do